The webinar will begin. We appreciate everyone joining us today, and we are very excited to have Deborah Buckles joining us today for this webinar. She is expert on the intersection of cancer, tobacco use, and mental well-being. I have worked with Deb Buckles for many years with tobacco control, and she is the tobacco control lead of the IU Simon Comprehensive Cancer Center's Office of Community Outreach and Engagement. That is a mouthful, and you can tell that she is an expert. So this webinar is being recorded and added to the IRHA resources for all of our members around the state. Just a few quick housekeeping items before we begin. As I mentioned, we are recording today's session, and it will be available on IRHA's YouTube channel within 1 week once the recording is processed. If at any point during the presentation you want to ask a question, please use the Q&A function. This function is accessible by hovering your mouse over the screen. It should pop up either at the top or bottom of your screen, depending on what view mode you are in. IRHA staff will keep an eye out for those questions and will moderate for Deb so that she does not have to check them while she presents. Thank you, Deb Buckles, for joining us, and you may now begin.
Thank you, Tina. I appreciate that introduction. And yes, we have worked together for many, many years, and it's always a pleasure working with you and IRHA. So thanks for having me today. So good afternoon, everyone. It is 12:01, so I can officially say good afternoon. I think it's quite pertinent to talk about this topic this week, especially since it is Mental Health Awareness Week. I think it is an opportunity to talk about the intersection of all of these things, particularly about mental well-being, but cancer and tobacco use do impact mental well-being. So I appreciate this opportunity to be here at this time during Mental Health Awareness Week. Mouthful too. So here are our objectives for today. We're going to talk about why people with mental health and substance use disorders are more vulnerable to cancer. We're also going to talk about the intersection of tobacco use, behavioral health challenges. So when I see behavioral health, I mean mental health and substance use. So one term to represent both. And then we're going to talk about some tools and resources. So during my presentation today, I want to make clear that when I say tobacco, I'm referring to commercial tobacco products and not traditional or sacred tobacco. So just want to make that distinction. So today we hear a lot about health equity. In addition to physical health equity, though, we need to address the importance of behavioral health equity. So everyone deserves a fair and just opportunity to be as healthy as possible. And this includes adults with behavioral health conditions who smoke and want to and are able to quit, but are even less likely to be offered proven assistance to help people quit for good. Another thing I want to point out here is that tobacco use disorder is the most prevalent substance use disorder. However, it is also the most underdiagnosed and undertreated substance use disorder. Nicotine is as addictive as cocaine and heroin, yet it is rare that people are offered the same level of treatment and assistance for tobacco use disorder as those addicted to illicit substances and even alcohol. So keep this in mind when you think about health equity. This slide provides examples of how tobacco disproportionately impacts groups facing disadvantage. These populations continue to see increased rates of smoking, and those individuals are people that report 14 or more poor mental health days. Those ever diagnosed with depression and those that are uninsured are seeing smoking rates twice their individuals in their same groups that don't use tobacco. So individuals who report less than 14 or poor mental health days have never been diagnosed with depression or are insured, their smoking rates are half of those other individuals. So it's really important to think about these groups as we think about health equity. And we have to not assume, but we have to consider the fact that the individuals in these groups that we're seeing are smoking at very high rates. And this injustice results in significant deaths related to tobacco use. It's reported that more than 480,000 deaths each year are the direct impact of tobacco use. And you can see that more people die from tobacco use in this bar on the far right of the graph than from all the other factors combined. And the line here, showing the red bar, represents the number of people with behavioral health issues that die from tobacco-related diseases each year. So approximately 200,000 people with behavioral health conditions. And cigarette smoking remains the leading cause of preventable death, disease, and disability in the United States today, primarily among this population. So while we're seeing a decrease in smoking rates in the general populations, we are not seeing that translate into this behavioral health population, partly because they are not receiving access to treatment. So when looking at adults with any mental illness, we see that they smoke at twice the rate of the general population. But what's also important to see here is that they smoke more cigarettes, approximately 2 packs per month more than those in the general population. And it's important too, because smoking can impact how the medications they take work. So the medications aren't as effective if they smoke. And we'll talk more about that in just a little bit. But among adults with substance use disorder, we see smoking rates almost 3 times that of the general population. And this is especially challenging for this population because fewer of the systems of care offer evidence-based tobacco treatment. And we know that smoking can increase their likelihood of substance abuse relapse. And we'll talk more about that in just a bit too. So smoking may impact the course of treatment, specifically the smoke. And we'll talk more about that in just a couple of minutes. So this slide is showing tobacco use rates or smoking rates specifically by diagnosis, by behavioral health diagnosis. And what you see is a striking, well, at least to me, it's very striking that we see very high rates of tobacco use, as high as 90% or higher in adults diagnosed with schizophrenia, alcohol abuse, and other substance use. But then also very high rates in individuals diagnosed with major depression and bipolar mood disorder. So individuals are more likely to use other substances such as methamphetamines, cocaine, and opioids. And that's because tobacco use has become a part of their ritual of substance use. So just before, during, and after substance use. And we also know that tobacco use or nicotine does what they call boost the high of these substances too. So we need to keep this in mind. While there's been no direct link that nicotine causes mental health conditions, we do have some new studies that found that nicotine can worsen symptoms of depression and anxiety. And additionally, I have to include e-cigarettes here. We can't have this talk about tobacco and not include e-cigarettes, but we do see current e-cigarette users have a doubling of the odds of having a diagnosis of depression. And those that vape frequently are 2.5 times more likely to have a diagnosis of depression. And then furthermore, vaping is significantly associated with higher levels of ADHD symptoms. So we know that smoking exacerbates symptoms of behavioral health conditions, including greater depressive symptoms, increased suicidal behaviors, which are suicidal ideations, suicidal attempts, and suicide completions, as well as greater likelihood of psychiatric hospitalization and drug and alcohol use relapse. But when people quit smoking, that can have some very positive mental health benefits. We know that when tobacco dependence treatment is delivered during addictions treatment, it's associated with a 25% increased likelihood of long-term abstinence from all substances. And this is really, really key. Most behavioral health providers still believe the fact that, well, when you're trying to quit one thing, you really shouldn't think about trying to quit smoking. And that's actually not true. We have evidence to prove that it is a 25% likelihood of long-term abstinence. I told this to one addictions provider at one point, he's director of a program, and he was like, that's like winning the lottery, Deb. We've got to tell patients about this. We also know that nicotine negatively impacts our youth, and we can't forget about our youth here. Teens, and even many adults for that matter, think that e-cigarettes don't contain nicotine. However, this study cited here showed that researchers found that 40% of teens who thought they were using nicotine-free products actually had cotinine, which is a metabolite of nicotine, in their urine. So that goes to show that there is nicotine in these products, and these are tobacco products. We also know that e-cigarettes are more addictive because they deliver nicotine salts, and that is less harsh, so individuals can ingest more of it. It's easier to ingest, and that's why kids are getting started on these products. And it also delivers a more concentrated amount of nicotine that reaches the brain faster, which increases the likelihood for addiction. And most alarming is that we know that these products that contain nicotine are especially concerning because nicotine permanently impacts learning, attention, memory, mood, concentration, as well as impulse control. And not to mention, nicotine use increases the teen's susceptibility to addiction of other substances. We also know that teens that use e-cigarettes, 40 to 60% of them will move on to combustible cigarettes within 18 months. So we need to really be concerned about our youth and their consumption of nicotine products. Not only does nicotine have mood-altering effects that can temporarily mask the negative symptoms, but daily tobacco use is associated with an increased risk of psychosis and an earlier age of onset of psychotic illness. And heavy smoking is a significant risk factor for major depression. Tobacco smoke can, and we'll talk more about this in a little bit too, but tobacco, as we mentioned earlier, tobacco smoke can interact with and inhibit the effectiveness of certain medications that mental health and substance abuse patients use. And that's important because if it increases metabolism, that means they may need higher dosages of the medications to get the same effect that somebody that doesn't smoke. And so I want you to think about this a second. What's the problem with that? Why are we concerned about patients having to take a higher dosage of medication? Think about if they are taking a higher dosage, what's one of the main reasons people don't like to take these medications? It's typically side effects, right? So not only side effects, but when they go to the pharmacy to pick up their medication, these higher dosages cost more money. And in this population, we already have trouble with them wanting to take their medications because they don't like the side effects already. And so this just adds to the issue of non-compliance of medications. So another thing to think about with this group is if they are on a higher dose of medication while they're smoking, and either they are admitted to an inpatient unit, or maybe they decide on their own to stop smoking. What could happen if they're on this higher dosage of medication? Well, it's very likely that they'd have too high of a dosage and have some symptoms related to that. So we want to be careful, and we want to think about that in patients. Or if you're an individual that's using tobacco products and taking some of these medications, I want you to be aware of that very important fact. People with substance use disorder who smoke are also 4 times more likely to die prematurely from those who don't smoke. Smoking is a very strong predictor of risk for non-medical use of prescription opioids, and people with mental illness on average die 10 to 25 years earlier than those without any mental illness. We know smoking is a major contributing factor to the heart disease, lung disease, and cancer, which are the typical causes of death for this group of people. We also know that more than 50% of patients with terminal cancer have at least one psychiatric disorder. And so that's very concerning because we have people developing cancer and it's due to late stage diagnosis, inadequate treatment, and lack of screening. So one thing that's really important to note too is that more people die of lung disease, heart disease, and cancer with substance use disorder than the alcohol or drugs that brought them to treatment. And so we are doing a disservice to these patients if we are not offering them evidence-based tobacco treatment. There are also many other consequences for this group of people. If they are using tobacco, the other consequences include things like financial hardship. We know that people with that are receiving disability income with mental health disorders are typically spending a third of that disability income to purchase tobacco. And those are financial resources that could be used to acquire housing, clothing, food, prescription medications. And so it's really important that they understand that and that we help them overcome this addiction. Tobacco use also interferes with gaining employment because a lot of employers don't want to hire people that use tobacco because they have to go outside to smoke, or they're sick more often and they're calling in. It also makes it difficult to secure housing because many landlords don't want to rent to people that smoke because of increased risk of fire, the smell of smoke in the house after the individual moves out, and having to replace carpet because of burns and things like that. So it's important consideration for many reasons. So good news is, though, that some recent studies have looked at readiness to quit among individuals with mental illness, and we have found that in the general population, about 20% of people intend to quit within the next 30 days, and another 40% intend to quit in the next 6 months. However, when we look here on this slide, among people with mental health or behavioral health diagnoses, we see on average people that are in the high 20% range with the intent to quit in the next 30 days or the next month, and anywhere from 41 to 55% intend to quit in the next 6 months. And so this tells us that individuals with mental illness or addictive disorders are just as ready, if not more so, ready to quit than people in the general population. And this is contradictory to what most behavioral health providers think too. And so why are rates higher among persons with behavioral health issues? Well, there's lots of reasons, and a lot of them are due to the tobacco industry. They have a lot of blame. For years, they have used many strategies to market tobacco and cigarettes to vulnerable populations, including those with behavioral health conditions. Some of the strategies include things like you see here on the screen, financial contributions to organizations that work with people with mental health disorders. They even funded research to show or to foster that myth that people needed to smoke to reduce stress or alleviate negative mood. They provided free and reduced cost cigarettes to psychiatric facilities. They supported efforts to block smoke-free and tobacco-free psychiatric hospitals, and they created specific marketing plans to target marginalized populations. I think the one that was most appalling to me was the R.J. Reynolds project called Project Scum, which was as recent as the 1990s. And this project specifically targeted the homeless and people with mental health disorders. You can see a lot of these documents. There's like 14 million documents listed here, are housed here at the Truth Tobacco Industry at this link. So if you want more information, feel free to go here to this link. And here are some examples of their more recent marketing strategies. using that stress relief theme. The tobacco industry has invested significant resources to connect tobacco to mental well-being. And this theme can be seen in many tobacco ads, including one early Camel ad that pictured people relaxing with a cigarette, and it read, "It's a psychological fact. Pleasure helps your disposition. For more pleasure, more pure pleasure, have a Camel." And to the long-running Newport marketing campaign featuring the tagline, it's up here in the top right, featuring the tagline "Pleasure," and that shows people doing pleasurable, carefree activities. I don't see a cigarette in his hand there, but they are linking pleasure to tobacco use. And now we're seeing many e-cigarette brands that are tapping into this theme of stress relief and mental well-being is here, as you can see in the top as well. And then, of course, saying goodbye to sleepless nights. And another brand, the brand Puff Bar, which during the pandemic marketed its product as "Stay Sane," and the perfect escape from back-to-back Zoom calls, parental texts, and stress. Who is it you think that they're targeting with that phrase, parental texts? Yeah, they're not marketing that to adults, are they? Although they say they only market their tobacco products to adults. But in addition, it's been well documented that this industry has targeted many other marginalized populations as well. So mental health challenges are common, and many people experience at least one behavioral health crisis in their lifetime. A cancer diagnosis can often be a contributing factor to mental health challenges, or it may be that the person had a behavioral health challenge prior to their cancer diagnosis. Chances are you or someone you're close to has experienced a behavioral health challenge. So you're probably familiar with what this is like and how it can impact a person, and not only just that individual, but their entire friend and family circles. 1 in 4 adults have had some form of mental illness or substance use challenge. And that challenges affects patients in all stages of cancer, from prior to a cancer diagnosis to during treatment, or maybe even in remission. And up to 50% of patients with a terminal cancer have also been diagnosed with at least one psychiatric disorder. And so those mental health challenges, sadly, are 30% more likely to die from cancer. So I think it's really important that we talk about this and address mental health challenges in relation to cancer. People with serious mental illness, such as bipolar and schizophrenia, are at an increased risk of dying from cancer compared to people with mild or moderate mental illness. Overall, the total cancer incidence is more than 2.5 times higher among adults with serious mental illness versus those without any mental illness. And so why do we see this elevation in specific types of cancer? Most people think of smoking, of course, when we think about lung cancer, but smoking has been shown to cause more than 14 different types of cancer. There are many risk factors, though. In addition, specifically thinking about colon cancer, the risk factors are less known, but may be related to smoking, of course, but also sedentary lifestyle, as well as diets high in fat and low in fruit and vegetables. As far as breast cancer in particular, we could think about the low rates of childbearing, which could contribute to breast cancer, but also smoking. And then also some psychotropic or medications used to treat psychiatric disorders can increase levels of prolactin, which can also be a factor linked to breast cancer. Chances are you or someone you know has been impacted by cancer, and therefore you all know how distressing it can be and how it impacts, again, just not the individual diagnosed, but all the friends and family that care for that individual. So people often fear how they're going to pay for their medical bills, if they'll have a job when they're done with treatment, or will they be able to do that job after treatment. They often have concerns about body image issues. And of course, concern about if or when the cancer will come back. And there are many risk factors that make individuals with mental health or substance use challenge particularly vulnerable to cancer. A couple of those we've just talked about, but that also includes negative coping mechanisms. In addition to smoking is also alcohol use or other substance use like opioids or alcohol. And then of course, we've also mentioned nutrition or diet, with individuals typically having high fat diets, sedentary lifestyles, lack of fruit and vegetable consumption. But then also many may have metabolic changes as a result of the medications that they're on for their behavioral health challenges. And then of course, co-occurring chronic behavioral and physical health challenges can be common in this group, and which results in many medications being prescribed, which increases the opportunity for drug interactions that may increase the risk of certain types of cancer as well. And then, of course, we have to address social determinants of health, such as race, gender, and many more. Individuals with behavioral health conditions are often discriminated against by providers because of their bias, leading to delayed cancer screenings, delayed diagnosis, and of course, lack of treatment. And again, people with behavioral health disorders aren't offered supports and assistance for these risk factors such as nutrition and tobacco as often as the general population, because it's perceived that these people don't want to or can't make changes. I know I've said it before, but it's really important to address the fact that tobacco is firmly linked to at least 14 different kinds of cancer. Predominantly, people think about lung cancer, but there are many different types of cancer that are linked to tobacco use that people don't realize. Stomach cancer, colon cancer, uterus, bladder, kidney cancer, pancreatic cancer. These are all related to tobacco use. And according to the CDC and the Surgeon General, 40% of all cancers diagnosed and 30% of all cancer deaths are caused by smoking. Tobacco use is related to cancers throughout the body because in each and every cigarette, there are 7,000 chemicals. 69 of these 7,000 in every cigarette are known to cause cancer. But a lot of people say, well, how does cancer get throughout the body? Well, it's because when an individual inhales the tobacco smoke, these 69 known cancer-causing agents are in that smoke. That's inhaled into the lungs, so that's why you get lung cancer. But all of those toxins are then absorbed across through the lungs into the bloodstream, and then the heart pumps that blood throughout the entire body. And so that's why we see cancer in other areas of the body. And this is not just for those that are directly inhaling that tobacco smoke, but for those in the room or in the smoking secondhand smoke. So inhaling that smoke from the individual that is smoking. So this is something to be thoughtful about as well. And it's not the nicotine that keeps the individual coming back to smoking. Nicotine is the addictive product, but it is the other things in the tobacco smoke listed here and many others that have all the ill health effects that cause the cancer, the heart disease, and lung disease. We have many studies now to show that smoking impacts many different types of cancer treatments, including surgery. So we can have delayed healing, more wound infection. We can have complications related to anesthesia. And so it's very important that a patient quit before surgery, as far ahead of surgery as possible, at least 2 weeks or a month before surgery. But tobacco use can also affect radiation. So those toxins in that tobacco smoke reduce how well the radiation works and impact how well the body will handle the treatment. It also worsens side effects from radiation. And the same is true with chemotherapy. Tobacco use weakens the immune system, and then you have chemotherapy that also weakens the immune system. So it's like a double whammy to the immune system. But also tobacco use restricts blood flow by constricting blood vessels. And this reduces how well the chemotherapy can get to the area of the body where the cancer is. So again, it impacts how effective the treatment is. So again, the bottom line is that smoking worsens the side effects of these treatments and reduces the effectiveness of all of these treatments. This is a chart that talks about some chemotherapy or common treatments for patients with cancer. And again, remember we talked about the medications that patients need for mental health disorders. These medications are specific to cancer treatment. And again, it's the tobacco smoke that impacts how well these medications can work. So if an individual is taking any of these medications as well, they may again need a higher dosage to achieve the same effect. So patients who smoke should be recommended to quit and receive assistance in helping them to do so. And we want them to understand that these medications won't work as well, and they need to know that it would be in their best interest to quit. There have been also numerous studies, excuse me one second. There have also been a number of studies looking at side effects of cancer treatment. This particular study looked at 12 different common side effects among 947 cancer patients during and 6 months following treatment. And those that smoked were significantly more likely to report severe side effects during and 6 months after treatment. In addition to those worsened side effects, though, we also see that patients have more frequent toxicity. So their kidney or liver functions are decreased, or they have low blood counts, which then often leads to delaying or completely stopping treatment. So we don't want patients to have to experience that. So again, it's important to counsel them on the reasons for quitting. And additionally, the significant persistence of these side effects can also reduce quality of life. So we know many patients feel too stressed or overwhelmed with the recent diagnosis and the fact that they have these upcoming treatments, but we want patients to understand how important quitting or even cutting back can be to help their treatment be more effective. These treatments often have some unpleasant side effects, as we just talked about, but quitting can ease or reduce the impact of those. And the good news is that the 2020 Surgeon General's report found that quitting smoking had very positive effects, including increased survival of many types of cancer, especially lung cancer. More good news is that even when someone quits, even after a diagnosis, there are immediate benefits, not just related to cancer, but many other physical benefits. And as little as 20 minutes after quitting, all the way up to 15 years after quitting. And I think this is important to share with patients, the positives. So now that takes me to talking about screening and treatment disparities. We know that people with serious mental illness typically are not up to date with their recommended cancer screenings for breast, cervical, and colorectal cancer. The disparities, though, in screening are independent of race, income, education, and insurance coverage, as well as number of visits to a primary care provider. Multiple studies have identified potential reasons for this, including low income, lack of transportation, embarrassment of their mental health challenge, and others suggest population-specific reasons, including health service delivery factors such as lack of communication between the primary care provider as well as psychiatry, which contribute to these screening disparities. And other barriers specific to this population include stigma and discrimination. The stigma behavioral health challenges influences not only patient level, but provider and system level factors, which ultimately impact the person's quality of life and survival. We also know that these individuals may have difficulty seeking care, comprehending, and acting upon advice as a result of substance use or cognitive deficits related to their behavioral health challenges, which then severely impact the person going on to not only get the screening that might be recommended, but if they do have a positive cancer diagnosis, then receiving appropriate treatment. They may have a hard or difficult time understanding the results that they get, and therefore may not be able to make a good, sound treatment decision as well. So people with behavioral health challenges are very likely to have also experienced trauma, including 76% of adults with a trauma history experience at least one psychiatric disorder. 43 to 80% of individuals in psychiatric hospitals have experienced some form of physical or sexual abuse, and 51 to 90% of public mental health clients have been exposed to trauma. So we have to consider that and think about that. And these high rates of trauma among persons with behavioral health challenges tell us we must change our thinking from what's wrong with this person? Why aren't they getting screened? Or why aren't they getting treatment? To thinking more along the lines of what's happened to them. So for example, a woman who might not have had her cervical cancer screening might be an indicator of childhood sexual abuse or maybe even rape. And we know that PTSD is a common symptom post-cancer care for a number of reasons listed here on your screen. So behavioral health providers, I urge you, those of you that are on the call today, I urge you to consider playing a role. You can have a very critical role, in fact, in facilitating cancer screenings, but also in behavior change for lifestyle factors such as smoking and improved diet. Of course, I'm biased, so I would urge you to think about how to help an individual stopping their tobacco use, since that is the most prevalent form and the most prevalent form of substance use disorder and the highest contributing factor to cancer diagnoses. And we know that behavioral health providers are especially skilled in cognitive behavioral interventions, which are exactly what we use to help patients overcome tobacco dependence. So that takes me to some tools and resources. So for those of you listening in today who are healthcare providers and including behavioral health providers, we'd like to talk about the Ask, Advise, Refer method, which is an evidence-based brief intervention, which can be completed in less than 3 minutes. And even though there is a dose-response relationship, meaning the more intensive the treatment, the better the outcome, we know that even brief intervention in as little as 3 minutes can be more effective than no intervention at all. In fact, fewer than 5% of quit attempts are successful when people try to quit on their own with no assistance. We also know that tobacco users do expect to be encouraged to quit by healthcare providers, including behavioral healthcare providers. One study determined that of 12 health habits, including exercise, diet, alcohol use, tobacco use, contraception and condom use, substance use history, STD prevention and counseling about HIV prevention, testing, only tobacco history and tobacco counseling were significantly associated with full satisfaction with the clinician visit. So a clinician who does not address tobacco use during a clinical encounter implies that quitting isn't important. And I've had this happen to family members who've said, well, Dr. So-and-so didn't tell me I should quit, so it must be okay. So it was really important that we address this. And so for the first step is to ask. And in order to provide treatment or connect people with appropriate resources, it's essential to first begin to identify your patients who use any type of tobacco, including e-cigarettes. So we must ask all patients about their tobacco at every visit. And I realize some of you may see patients once a week, or you, if you're a patient, you may be seeing a provider once a week. But it's important to bring that topic up because people change daily, even in their thoughts about quitting. It doesn't have to be a full assessment. You can just say, what have been your thoughts since we talked about your tobacco use last? But it's also important to treat this as a vital sign. And it's important to start the conversation in a way to make the patient feel comfortable. So asking permission, would you mind if I ask you a few questions about your tobacco use? And then going on to one of these other statements here. The one I like most is, we care about your health and we have resources to help our patients when you're ready. So remember, when asking about tobacco use, use a non-judgmental tone of voice. We want to convey sensitivity, concern, and respect. We want to ask about all tobacco products, and to do so, we may have to specifically ask about vaping or name specific brands like Juul, Puff Bar, or Zyn, because a lot of times people don't consider those tobacco products. And then the next step is to advise patients to quit, again, using that non-judgmental tone of voice, and the advice should be clear and strong, but also be empathetic, and offering support is critical to letting people know that we care about them and we're here to help. Here are some examples of how to advise patients to quit. And this first one is around the conversation about vaping, because people feel like vaping is safer, but we know it may not be. So again, we want to address that. In the case of a patient that has been diagnosed with cancer, we could say, quitting will allow you to experience fewer side effects of treatment and improve how well the treatment works. The last step is refer. So for those patients who are ready to quit, we want to refer them to assistance and support. Many of you may have heard about the Indiana Tobacco Quit Line, and with their recent rebranding, they now call themselves Quit Now Indiana, but the phone number is the same, 1-800-QUIT-NOW. If you're not familiar with this, they offer assistance by phone, text, or web, and provide 4 weeks of free medication. They also have a behavioral health program, so those with the behavioral health condition can access more services. They get 7 phone calls. They also get 12 weeks of free medication, and that's combination therapy, so patch in addition to gum or lozenge. And these coaches have received additional training in behavioral health conditions. It's also important to talk to patients or your loved ones about a recovery date, setting a recovery date. I say that instead of a quit date. This terminology of recovery date has a little different connotation and less stigma. We also want to encourage people to think about self-monitoring, identifying activities such as situations that trigger tobacco use, or activities that would trigger tobacco use, and help them learn when and why they use tobacco, as well as developing some coping strategies, which we'll talk about next. So there are 2 different types of counseling strategies. Behavioral health providers are extremely skilled in using these, one being cognitive strategies that focus on thoughts that influence behaviors. And when we work with these patients, we want to help them identify and interrupt negative thought patterns and think about situations that help them. For instance, instead of thinking about how they're giving up smoking, maybe they could think about what they're gaining: better health, saving money, they won't smell like smoke, their treatment will work better, and they'll have fewer side effects of cancer treatment if they're going through that. Or they can practice positive self-talk. Things like, this is temporary, it's only going to last a few minutes, I can get through this. Or maybe, hey, I am stronger than this craving, I can get through this craving. And then, of course, behavioral strategies are things that are actions the patient takes to disrupt their tobacco use. For instance, if they crave or want a cigarette after a meal, they could get up from the table right away, go for a walk, go brush their teeth, things like that. So think of different things they can do. One strategy for behavioral strategies is called the 4 Ds: delay, drink water, distraction, and deep breathing. And then managing emotions is really, really important, not only in tobacco recovery, but also in cancer care. So mindfulness and meditation can be very helpful, and anyone can do them at any time. That reduces stress and anxiety, and of course, relief of withdrawal symptoms. What is it? What's the most reason people say they smoke? If you're thinking stress and anxiety reduction, you are right. So what's actually happening here is when they use tobacco and it's been 20 or 30 or 40 minutes, what's happening is they're actually experiencing nicotine withdrawal. So think about what some of those symptoms of nicotine withdrawal are. You yourself have either used cigarettes in the past or tobacco products, or maybe you know somebody that has. And when it's been a while since somebody's had a hit off a cigarette, they start to feel really uncomfortable, right? And it feels like stress. They feel anxious, nervous, restlessness. So when they start to feel these feelings, they think they're feeling stressed, but in actuality, they're feeling withdrawal. So when they take that hit of that cigarette or other tobacco product, what they're doing is relieving the withdrawal, but they think they're relieving stress. So there are many apps out there today, such as Headspace or Calm, that are easily accessible by smartphones. And these are great resources, and there's other ones available as well. But studies can confirm, though, that people that quit tobacco report reduced anxiety and depression after quitting. The last thing I want to talk about, the last resource or tip, is that we need to be thinking about medications. We know there's 7 FDA approved medications on the market today to help with quitting smoking and other tobacco products, but they're specifically indicated for smoking cessation. But we have to think about this as like medication assisted therapy for patients that are diagnosed with substance use disorder. These medications help reduce the nicotine withdrawal, which then allow the patient to focus on the behavioral and cognitive strategies. Most people are underutilizing these medications, and we know that medications, in addition to counseling, are more effective than either one alone. So we really want to see patients using medication because it's going to increase their likelihood of successfully quitting. It helps, like I said, it helps ease the discomfort of nicotine withdrawal. And even if you as an individual are in the healthcare field, or even if you are in the healthcare field but not a prescriber, it's important to know how to use these medications. There are a lot of things people don't understand or know. For instance, the nicotine gum is not meant to be chewed. It's meant to be chewed only until you start to taste it, and then it's meant to be parked in the cheek, and that's how the nicotine is absorbed. People that chew it constantly don't get the full effect of the gum. And then the lozenge, of course, you don't want to chew it. You want to park it in your cheek and allow it to dissolve completely. But it's really important that everyone understand how to use these medications, because these medications are most commonly not used properly or underdosed. And so the better we can help people use these medications appropriately, the more effective they're going to work. And a lot of times people think that these are a magic bullet. I'm going to use that patch and never smoke again. Again, these medications are only going to help ease the nicotine withdrawal. They're not going to completely eliminate it. So that's the end of the presentation today, but I did want to mention that this presentation was provided in partnership with a grant that we have called Rethink Tobacco Indiana. Oops, sorry about that. And so we do have some more information and resources on our website at rethinktobaccoindiana.org. And if you are with a behavioral health system or you are a behavioral health provider, we provide free technical assistance and support to you and your organizations. If you're interested, please contact Gage Van Dyne here at this email address. So thank you so much for joining us today. I hope this has been helpful. And with that, I will now open it up to any questions. I've also put my contact information in here. If you think of something or you have a question I haven't addressed today, don't have time to address today, please feel free to reach out to me or Gage at any point in time.
Debbie, this was such great information. And no matter how many times I have seen or heard your presentation and those of others, I continue to learn because this information is ever changing. I didn't realize there were that many different products out there now to stop cessation or to stop smoking. I do have a couple questions. One is, we talked about firsthand smoke, secondhand smoke. Can you talk about the effects of thirdhand smoke? And then finally, the effect on people's pets. I know sometimes people treat their pets like their children. And if you could talk about that, that might help those of us who do educate on tobacco.
Sure, absolutely. So third-hand smoke, we know first-hand and second-hand smoke. Second-hand smoke is what comes off the lit end of the cigarette or what the smoker exhales. Third-hand smoke is when that smoke deposits on furniture, clothing, other things, and people touch that, or that continues to do what's called off-gassing. So when the smoke is on something, it continues to emit those cancer-causing chemicals. And so that stuff can also be inhaled, or if in the case of a child crawling across the carpet that's contaminated with smoke, they can ingest that or touch it and then ingest it that way too. It can also be ingested through the skin. So that is what third-hand smoke is. And it can be dangerous as well. Obviously, the most danger is in the direct inhalation of smoke, but secondhand and third-hand smoke have dangers as well. And then as far as pets go, pets are secondhand smokers. They get third-hand smoke as well. And that's why we do see increased rates of cancer in pets among tobacco users. So it is very important. They not only just have cancer, but they can have lung problems. We know animals with short snouts are particularly more susceptible and vulnerable to the effects of second and third hand smoke as well. So it is important to think about those, our four-legged friends and family too, for sure. I'm glad you asked that question.
That's great. And I see no other questions in the Q&A function. So I believe that means you covered your topic and objectives perfectly. Thank you so much, Debbie. And for those who were not able to attend this session live, they will have access to the recorded version on our YouTube channel. So thank you again, and for the great work you and your organization does.
Thank you, Tina. Thanks for having us today.